Good morning, one and all. I am Dr. Avinash. I am a consultant gastroenterologist working at Ramaya Memorial Hospitals, Bangalore. Uh, as an event for World IBD Day, which is due on 19th of this month. So, to create public awareness of inflammatory bowel disease as part of initiative from Zydus, we are doing this people awareness campaign. Inflammatory bowel disease is of two or three variants. One is ulcerative colitis, second one is Crohn's disease, third one is IBD unclassified or indeterminate colitis, where we are not able to put into either of the categories because the disease has to evolve. The exact pathophysiology or pathogenesis of inflammatory bowel disease is not yet clear. So there are various hypotheses that determine inflammatory bowel disease depending on environmental or genetic, which is predominantly like based on different chromosomes which we inherit from our parents, or it can be environmental depending upon the dietary scenario, like what we ingest, because different type of bacteria can go inside and that can change the hormonal or the humoral or the cellular immunity. And whenever our own immunity is acting on our own intestines, then we tend to develop inflammatory bowel disease. So we don't have a natural history like in a X individual how the inflammatory bowel disease is going to progress. So whether they can have relapses and remissions, or it can be one relapse and then it can be under remission for the entire life, or it can be one relapse and it can go up like culminating in surgery and all. But we don't have a typical natural history like in a particular individual how the inflammatory bowel disease is going to progress. Depending upon the location of involvement, different people will come with different symptomatology. Predominantly, if the esophagus and stomach is involved, that is in Crohn's disease, they can come with ulceration strictures like presenting as abdominal pain or blood in vomiting, blood in stools, or they can have low hemoglobin, so that will be determined by anemia, we call it as, or they can be having indigestion or significant abdominal pain or loss of weight or loss of appetite. If at all it is a small bowel that can get involved, that is duodenum, jejunum or ileum. So again in Crohn's disease, like they can have again ulcers, strictures. So again they can come to us with abdominal pain, abdominal distension, vomiting that is containing both food particles as well as yellow fluid, what we call it as a bile, or they can come to us with low hemoglobin, weight loss, low albumin with significant amount of malabsorption of different food materials. If the carbohydrate is not getting digested, they can come to us with more bloating, more loose stools, weight loss. If the protein is not getting digested or absorbed, they can come to us with significant fluid in the abdomen or leg swelling or abdominal swelling, what we call it as ascites and pedal edema. If the fat is not getting absorbed, they can have oil in the stools, they can have weight loss, and they can have significant fat soluble vitamin deficiency. So if the colon is predominantly involved, they can come to us with multiple episodes of loose stools, which is predominantly like blood and mucus in the stools. Like predominant involvement is whether it is a right side colon that is involved or the left colon that is involved. They can come to us with like tenesmus, like feeling of incomplete evacuation of stools, like unclear stools. They can come to us with blood, mucus in the stools. Again, low protein can happen. Whenever colon is involved, it can be because of ulcerative colitis or Crohn's colitis. Crohn's disease can affect from mouth to anus, whereas ulcerative colitis is predominantly limited to the colon. So how does a gastroenterologist help in diagnosis of inflammatory bowel disease? We first do routine blood investigations to look at the general condition of the patient, and then we do a specific investigation to identify what type of inflammatory bowel disease are we dealing. Though the treatment is not going to matter, the outcome of a patient as well as the surgical modality is going to matter. In the general condition of the patient, we are going to look at the complete hemogram, the liver function test, the routine kidney function, the vitamin levels and all. In the specific gastroenterological test, we tend to do an endoscopy plus biopsy as well as a colonoscopy and biopsy to determine what exactly is the pathology. Coming to the treatment aspect, we deal treatment in two different headings. One is induction of remission, that is we need to get the disease under control, and then we need to maintain the remission, we need to maintain the disease in remission. To induce remission, to get the disease under control, we tend to use steroids or biologicals, that is either infliximab or adalimumab, to get the like anti-TNF. These are all what are called different mediators that are there in the inflammation cascade. So steroids and biologicals, these we tend to give for 3 months in tapering dose or an year time to get the disease under control. And then once the disease comes under control, we need to continue the standard of care, which are predominantly like a maintenance of remission, which is predominantly we tend to use mesalamine in ulcerative colitis, or we tend to use along with plus minus immunomodulator like azathioprine and methotrexate. So once the disease is under control, we keep the patients on the maintenance medicines for lifelong, because we don't want a flare of symptoms. We keep them on surveillance colonoscopies plus minus biopsies, because these are all pre-malignant conditions. Once the disease is under control, the patients also compliance will be better. We keep them on follow-up once in 3 to 6 months and ensure that they lead a happy normal life with medicines. And we wish all the patients, all the inflammatory bowel disease patients, to remain under remission by taking regular medicines and getting regular checkups. Thank you.